without wasting much time. So this is the role of atezolizumab in advanced non-small cell lung cancer in first-line setting. So there are these three trials which I'll be discussing: IMpower 110, IMpower 160, and IMpower 130. I'll skip the introduction part. Let's go on to yes. So what this slide tells us that in lung cancer, we've seen a lot of success. That is mainly because of the mutations, and that we are able to target them. Now, there are 35% of the patients where mutations are unknown. So immunotherapy plays an important role, especially immuno with chemo plays an important role in these patients. Now, the three trials, 110 is mainly atezolizumab monotherapy versus chemotherapy. IMpower 130 is atezo with chemo versus chemo. And IMpower 150 is whether addition of atezo to the standard of care, Bev with chemo, is it beneficial or not? So I'll come to them individually. Now, IMpower 110, where you see that whether atezolizumab monotherapy is compared to chemotherapy in case of non-small cell lung cancer, both squamous as well as non-squamous. Now, again, phase 3 randomized study where chemotherapy naive patients. So upfront, 2 arms, atezo monotherapy used in 1200 mg, 3 weekly dose versus for non-squamous, they've used PEM carbo-OSIS. For squamous, they've used GEM carbo-OSIS, 4 to 6 cycles, and then maintenance. Now, what this slide tells us that in this study, basically Pdl1 expression. So there are 3 varieties. One are high Pdl1 expression, that is TC3 or IC3, more than 50%. TC2 is kind of, mid range, and TC1 is just more than 1%. So basically all the patients are Pdl1 positive, more than 1%, more than 5%, and more than 50%. So the next slides, we'll be mainly talking about the patients with high Pdl1 expression, that is more than 50%. That is TC3 or IC3. Now, if you talk about the baseline characters, again, all of them are very well matched. So coming to the results, if you look at the overall survival in patients with high Pdl1 expression, so cases where we used single agent atezolizumab, we're getting a median OS of 20 months compared to 13 months only with chemotherapy. So again, it's a good 7-month survival, which is similar to the other immunotherapy, what we've seen. If you talk about the 12-month OS, it's 64.9% versus 50.6%. We're getting a hazard ratio of 0.59. Now, if you look at the subgroup analysis, single agent atezo has done well in all the subgroups except patients with age group more than 75 or who've never been smokers. Now, coming to the PFS, again, we see a nice separation of the curves. If you talk about the median PFS, there's a benefit of around 3 months. If you look at the 12-month PFS benefit, again, statistically significant, 36.9% versus 21.6%. So we're getting a good PFS benefit as well. Coming to the responses. So if you talk about the response, it's 38.3 versus 28.6%. And median duration of response after a follow-up of around 29 to 30 months has not been evaluable in case of atezolizumab versus it's around 6.7 months in case of patients with chemotherapy. So it's again, that is quite significant. Safety profile, obviously single agent immunotherapy does much better than chemotherapy. Important thing to see in this slide is even with immunotherapy, we don't see much of immune mediated side effects. And the use of steroids was used in only 10% of the patients in atezolizumab arm. Adverse effects, obviously more with chemotherapy, things like anemia, nausea, neutropenia, constipation. More frequent with atezo were mainly pruritus, AST elevation, hypothyroidism. So to summarize, atezolizumab is promising in first-line therapy with high PDL1. It gives a significant OS and a PFS benefit. Safety profile is definitely better. We've not seen any new unexpected side effects. And the patients treated with atezolizumab had a longer treatment exposure than patients treated with chemotherapy. Coming to the second study is IMpower 150. This is mainly non-squamous. So the first one was non-squamous as well as squamous. This is only non-squamous. So here they try to find out whether addition of atezolizumab to the already standard of care, that is Bev plus chemotherapy, in patients with non-squamous metastatic non-small cell cancer, how beneficial it was. Again, phase 3 study. So all non-squamous stage 4 non-small cell lung cancer, irrespective of the Pdl1 status. That is important. And without any kind of mutations, EGFR ALK negative. So 3 arms, atezo with chemo, that is A. B is atezo with chemo with Bev. This is the important arm, experimental arm. And C is the standard of care, that is chemo with Bev. And all of them were continued into maintenance. So this was the hypothesis that when atezolizumab's ability to restore anti-cancer immunity through T-cell mediated cancers is enhanced by VEGF-mediated immunomodulatory effects. Baseline characters, again, well balanced. Important thing to note here is that liver mets was specifically highlighted in the study, and they tried to see how addition of atezolizumab has done better in patients with liver metastasis, as well as EGFR mutant patients were taken in the study, that is after the first line TKI. So coming to the overall survival curves, we see significant survival benefit. If you look at the median OS, it's a difference of around 5 months. And at the end of 2 years, we're getting a hazard ratio of 0.80. So there's a 4.5 month clinically significant median OS benefit. Next slide. If you look at the responses, now addition of atezolizumab to Bev plus chemo does well irrespective of the Pdl1 status. That is what is seen, that we get a median duration of response of 11.5 months when we add the drug, compared to only 6 months in case of without immunotherapy. The important thing is that patients with high Pdl1 have done significantly better. So if you look at the second part of the slide, there's a median duration of response of 22.1 months in case of high Pdl1 level, compared to only 7 months. Yeah. So again, the OS benefit also was better in patients with high Pdl1 levels, where we see a nice separation over the curve, 25.2 months compared to 15 months. Now, in case of patients with EGFR mutation, so these patients which had EGFR mutation, the sensitizing ones, that is exon 19 or L858R, who have been exposed to prior TKI therapy, around 10% of the patients were in this this group. What we saw was the curve started separating at the end of 6 months, and we get a difference of around 3 months in case of overall survival, which is again statistically significant, giving a hazard ratio of 0.59. Talk about the OS benefit in patients with sensitizing EGFR mutation, comparing arm B and arm C. Again, getting a good a difference, a nice separation of the curves, where this thing is 29.4 months compared to 18.1 months. So again, patients with EGFR positive who failed the first line TKI therapy have done well with atezolizumab when added to Bev and chemotherapy. Now, if you talk about the responses in patients which are EGFR positive, so the ORR increased from 42% to 71% with addition of atezolizumab to Bev plus chemotherapy. Interesting thing is 6% of the patients achieved a complete response. Now, liver metastasis. Now, patients with liver mets, all of us know that it is a negative prognostic factor. So these patients were specially highlighted in the study. And what they realized was, when we add atezolizumab to the combination of Bev and chemo, we get a nice separation of the curve when you talk about the PFS. There's a difference of around 3 months, which is again quite significant. And if you look at the end of 1 year, we're getting a PFS of 34% with atezoli and Bev and chemo, and only 1.8% with only Bev and chemo. Now again, OS in patients with liver metastasis, getting a median OS of around 13.3 months compared to only 9.4 months, which is again statistically significant. And at the end of 18 months, again, it's around 34.9% versus 11.5%. So talking about the response in patients with liver mets, 60.8 versus 41%, and the median duration of response is 10.7%, 10.7 months when atezo is added to Bev plus chemo. Now, again, another interesting thing is patients with bulky disease. So what they saw was that taking patients which had bulky disease, how they've calculated is they've taken the sum of the longest diameter or number of metastatic sites. What they saw was, irrespective of the burden of the disease, atezo along with Bev and chemo have done well compared to only Bev plus chemo. That is first thing. Secondly, patients with a higher burden of disease, who have a more bulky disease, they've even done better. So the bulkier the disease, better the response, better the survival when you add atezolizumab to Bev plus chemo. Talk about the side effects. Obviously, when you're adding 4 drugs, the side effect profile was worse. We are seeing more side effects. If you talk about the serious adverse events, it is around 44% compared to 34% in the other arm. But the results, what we've got, especially with patients with bulky disease and liver mets, I feel addition of the drugs has made a difference. So the conclusion would be, it's a positive study in first-line non-squamous non-small cell lung cancer with a statistically significant and clinically meaningful improvement in both OS and PFS. This clinical benefit was observed in key subgroups where EGFR was positive and liver mets. Safety profile was pretty much expected, and patient characteristic beyond Pdl1 expression may be considered when taking immunotherapy treatment decisions for non-squamous non-small cell lung cancer. I'll skip this part. Okay. Now the last study was IMpower 130. Again, non-squamous histology. Here it is a phase 3 study where we saw with the addition of atezolizumab to chemotherapy, or chemo with or without atezo, how fairly it has done in non-squamous histology. So the goal of chemo immunotherapy combination is to create a more favorable environment to maximize the potential of immune system to eliminate cancer. 2 arms. One was atezo with nab-pacli and carbo. The reason they used nab-pacli was to basically see the steroid sparing effect of the chemotherapy regimen. So we were trying to use a chemo where steroids can be avoided to enhance the effect of immunotherapy versus the chemotherapy arm. And then maintenance of atezolizumab versus switch maintenance of pemetrexed. Now, the important thing to note here is that there was a lot of crossover in the study from arm B to arm A. So despite the protocol amendment, around 41% of the patients in the control arm crossed over to the atezolizumab arm, with a total of 59% of the patients in the control arm receiving subsequent chemoimmunotherapy. Why this is important, I'll come to this later. Now, the baseline characteristics were well balanced. We'll talk about the age, the sex, the liver mets, bone mets, etc. Investigator assessed PFS was significantly improved when you add atezolizumab to chemotherapy. So we see a median PFS of 7 months with atezo with chemo compared to 5.5 months. So the difference is 1.5 months. But if you look at the 12-month PFS, it's actually doubling. So at the landmark 12 months, the PFS was doubled from 14.1% in case of chemotherapy versus 29.1% when atezolizumab was added to chemotherapy. So PFS was significantly improved. When you talk about the OS, although we see a separation of the curve, it is not that, the separation is not that much, which could have occurred because there's a lot of crossover. So a lot of patients who've received chemotherapy went on to receive immunotherapy. But still, we are able to find a difference of around 6 months. So OS was also significantly improved in intention of treat population. And at the end of 2 years, getting around hazard ratio of 0.79. Looking at the forest plot, again, although a lot of things are favoring atezo with chemo, but because there's a lot of crossover, we're not able to comment much with this forest plot curve. Now, patients with EGFR ALK positivity were also assessed in this trial, but we don't see much PFS or OS benefit. What we saw in the other trial, that is IMpower 150, when Atezo was used with Bev along with chemotherapy. In those patients, even EGFR positive patients had done well, but here in case of Atezo and chemo, they're not doing that well. When you talk about the responses, the overall response as well as the duration of response, both were improved when Atezo was added to chemotherapy. The median duration of response was around 8.4 months versus 6.1 months, which was again statistically significant. Talking about the safety profile, again, there was a higher proportion of treatment-related grade 3, grade 5 adverse events, which was again expected when you're adding immuno to chemotherapy because of the additive effect. So coming to the conclusion, IMpower 130 was a positive phase 3 study where Atezo, in case of first-line non-small cell lung cancer, provided an alternative chemoimmunotherapy plus chemotherapy regimen for patients with chemotherapy-naive non-small cell lung cancer. It demonstrated a statistically significant, clinically relevant OS benefit when Atezo was added to chemotherapy, despite a high crossover rate. It demonstrated a PFS benefit and a higher response rate. The OS and PFS benefit across all the clinical subgroups had shown benefit, but excepting the EGFR positive patients. And Atezo with chemotherapy had a safety profile consistent with the adverse event associated with single agent therapy. Thank you.
Hi, thanks Dr. Taha for such a wonderful talk. The next talk would be by Dr. Shrikant Tiwari, sir. It will be on Ceritinib, a frontier in the first line treatment of ALK positive non-small cell lung cancer. Sir.